Time to go live.
So the 30-second left. Sir.
Okay. So all the faculty, only we are on the Zoom platform. Rest all the viewers are on another web stream, which is given to them the link. So they won't be seen here. Only invited the guests are here, like Dr. Chetan is there, Jalil is there, like that.
So can we start, sir?
Yes, please.
Okay,
Yes,
sir.
Nitin, best, please.
So please start in 3, 2, 1. Please start, sir. We are live.
Okay. Well, good evening, friends. All those who have joined the web stream platform, and of course our dear faculty and invited guests on the Zoom platform here. We are back again with this Gujarat WhatsApp group webinars. We have been doing this type of webinars for last more than 10 years, and this year we started in the month of March. So we had labs in hematology, then we had two on the tuberculosis, then we had two on the vaccines, one on the juvenile idiopathic arthritis, we had two on nephrology, and the last month, I mean the month before that, we had on the growth and the monitoring, and these were all very well appreciated. So this is the 12th program. Last month we took a break because of the festival season and lot of heat generated by the IP election. I hope that fire is doused now and we are back to our academics. Maybe next month we will decide, because Pedicon is also there, so people might be tired listening to so many lectures. So we'll decide about whether we want to skip January too, but we'll come back with that later. So today we are here to discuss with very illustrious faculty from the gastroenterology and hepatology section, something on the hepatitis in children. So we will leave the neonatal hepatitis because that itself is a big topic, and we will just discuss the other so-called acute hepatitis, which may be viral or otherwise, and those nitty-gritties we will discuss as the time goes. And now I request Dr. Ramesh Bajania to say opening remark and introduce our faculty.
Good evening, respected seniors and dear friends. And today yet we are with one more webinar. We always keep such type
Little
of
louder.
webinars. We organize these webinars considering a common pediatrician who is practicing in day-to-day life with minimum support of investigation. Basically, Nitin Bhai prepares cases in such way. Today we have got eminent faculties, Dr. Anupam Sibar, who hardly needs introduction, but still those who don't know him, he's uh, group medical director at Apollo Hospital Group, New Delhi. We have a very senior and eminent gastroenterologist, Dr. Malti Mem, who is at MGM Hospital, Chennai, and our young lad from Gujarat, Dr. Ashay Abhaisha, who is having his PRISM Pediatric Gastroenterology Clinic. So about today's webinar, Nitin Bhai has come out with different cases, and first we'll take hepatitis A, which representative as a representative of a common pediatrician, I would like to take. Now straight away, let us go to the business multi-mem. 3 years old child presents with loss of appetite, vomiting and mild fever for 8 days. On inquiry, he also has dark urine. This is what mother says. So how to interpret dark urine, ma'am?
So good evening, Dr. Nitin, Dr. Ramesh, and all the team and my co-panelists. It's really wonderful to be here, and I consider it a privilege to be here. Though it's the end of the year, 2024 has been good and bad, but it's nice to be on the platform. So this interpretation of dark urine, very interesting that sign is noted by the parent. Especially we say, they tell us, my child is passing dark urine, doctor. Could it be that the child has something in the liver, or even if that they've noticed, they notice the jaundice? So it is something which is brought by the mother. So it's a very important thing. And sometimes as doctors, as we do more studies, we forget about this simple symptom. It is very, very important. And what is it due to? Is that's what we want to know. It is because of the presence of conjugated bilirubin. Therefore, it will be present only in the hepatitis, hepatocellular, and in obstructive jaundice. It will not be there in hemolytic jaundice. Therefore, that jaundice is called as ecolic jaundice. That is, the urine will be white, but still the child will be jaundice. So I think 3 points which we should remember is, it is a very important symptom. A dark urine indicates that the child is having something in the liver. It must be either hepatocellular or obstructive jaundice, apart from other causes. And second is, in hemolytic jaundice, the urine will be white. It will be normal in color because unconjugated bilirubin is not soluble. It does not dissolve anything. And third one is, I use it practically to tell my patients, tell the mothers, keep watching this urine. As the urine becomes lighter, you know that the child is improving. Very simple. You don't have to keep doing blood tests. The child's improving, and especially I ask them to compare the morning, evening, and evening urine. If they have 2 test tubes, I ask them to keep it in their bathrooms and see that, wash their hands after that. But as they watch, they will find that the morning dark urine becomes as light as the evening urine, and both will become lighter. Very simple, rather than poking the child. So I think very good. I am so happy that you brought out this fading symptom. We don't think
Martin, what happens that most of us prescribe B complex,
yes, that urine.
So after B complex also that urine comes yellow. So how you
that is a different thing. That is after, when this is a child who's coming with symptoms and high colored urine.
Correct.
So this is not a general child. That they also know. They will tell you their child took this, it took that. That yellow is also different. And this, suppose actually when we are, I think Dr. Anupam will agree. We used to say, but we are not including that neonatal at all. But we used to say, does it stain the diaper? This is a very bright colored yellow urine. And I think we are not going to exclude that. But I used to always say the gold should become platinum. Then that is the improvement. So I think very important. You brought a very, we are forgetting about this very important symptom which God has kept for us to know, see, and make a diagnosis. And
So
that
I would just add to say that if you have a highly concentrated urine in a dehydrated child, it could become a little dark. Other drugs like furazolidone in the past we used to use.
Those are spurious. But here you brought a child who has lost appetite, vomiting. So look at everything. So
yes, absolutely. And I mean, Madam very rightly said that the hemolytic jaundice will not be having dark urine. They can have cola colored urine. So you have to ask the mother, is the color like turmeric or is like thumbs up or cola? Then she can differentiate. And I mean, when I go for rounds and if there is such a history and if the residents have not kept the urine for me to see, I fire them because you see, you can make a difference.
Now they don't want beeturia. Nice pink colored urine you will have, all colored.
Absolutely.
So I think urine color we should not forget, and I'm so happy this was included.
Right. I think before we progress, Dr. Ramesh, we forgot Dr. Trambak. Please, today, I mean, every time we have a sponsor which is Zydus. Just 1 or 2 lines about Zydus, Trambak, before we carry on to the business again.
Yeah, sure, sir. Thank you so much.
Trambak is the medical head at Zydus Vaccicare.
Thank you so much, sir. Thank you, everyone, for this opportunity. I hope you can see the screen.
Yes.
So I am Dr. Trambak. I'm the medical advisor at Zydus Vaccines. And as you all are aware, we are a well-integrated pharma player with a proven track record. Over 23,000 people impacting lives across 4 continents. 300 plus generic products. Along with that, NCEs, NBEs, vaccines. More than 1,400 research scientists. Launching products that not only address unmet healthcare needs, but are also innovative pillars like Lipaglyn Exemptia, India's first tetravalent influenza vaccine, Twinrab, Bilipsa, Zycov-D, and Oxemia. So I'll just take you through the journey. For Zydus vaccines, we launched the type 1 and Hep B back in the 90s, then Vaxirap N in 2000, acquired the Italian Itna Biotech in 2008, 2010. We launched Vaxiflu S. Vaxiflu 4 was launched in 2015, followed by the division of Vaxicare, Zyvac PCV, followed by Twinrab, and then, of course, Zyvac MMR, and so on. So these are all the Zydus vaccine you can see on board. And Vaxiflu 4 now comes with the 25G Terumo needle, with the advantage of it being recommended across all the age groups. And thank you so much for the opportunity once.
Thank you.
Thank you, Trambak. Zydus has always been the pillar of support for all these webinars. Ramesh bhai, continue.
Yes.
Second question.
Yes.
Yeah.
Now, Ashay,
Yes.
what about yellow eyes? Because if a patient comes directly to us during early part of illness, then the eyes will not be yellow.
Yes.
And once the eyes are yellow, then even grandmother can diagnose. Then where these eyes should be observed? Because many a times a consultant is practicing in a very dark area. Sometimes the yellow wall is there. So can you elaborate about this
Yes, sir.
cardinal sign?
So, a very good evening to one and all, and I'm thankful to respected Nitin sir and Bajania sir for giving me this wonderful opportunity. And I'm thankful to my teachers who are sharing the same platform, and I am blessed and honored. I hope they will like my presentation, and I will do my best. So, coming to the sir's question, usually these yellow eyes reflects the presence of a jaundice. It could be due to hepatobiliary injury or any hematological injury. Usually, but madam has said that high colored urine with jaundice, what we call the deep jaundice, is usually seen in an hepatobiliary disorder, and only somewhat a yellowish tinge is seen in hematological disorder. And absence of yellow sclera does not always rule out the hepatitis, because recently we encounter many atypical hepatitis in our day-to-day practice. So a high colored urine with deep jaundice is an main important pointer to diagnose this viral hepatitis with prodromal symptoms.
So the only condition where I would say that there are quite deep yellow eyes or quite I mean, significant yellow eyes in a hemolytic anemia is a sickle cell anemia. I mean, that's something which we should never make. They can have bilirubin of 5, 6, 7, 8 all the time. So that's one thing. And of course, I mean, you are a better hepatologist, but Gilbert syndrome can come with only a direct bilirubin, not of hemolytic cause, but still will have yellow eyes, but a normal colored urine. So I think that's how you have to interpret urine color and eyes color together to come to semblance as to is it choliuric, acholiuric, means is it direct or is it indirect? Go ahead.
So
But I was just tell one point, sir.
Yes, ma'am.
Yes, ma'am.
Hepatitis A is so common. I think Dr. Anupam and Ash will agree. We have a bunch of anictic hepatitis.
Yes,
And I think that we should not forget. Just because the eyes are not yellow, or
correct.
eyes yellow only means jaundice. Jaundice means yellow, but that doesn't mean they don't have hepatitis. And that is missed sometimes, because anictic hepatitis will be forming quite a number, especially in A, and the younger children will have anictic.
Correct.
Now, as a general pediatrician, whenever we get a suspected case of, because mostly it is apparent from the history, then the question comes that which investigations to send. Few send direct only serum bilirubin, few send serum bilirubin and SGPT, few send total LFT. So, which are the basic investigations when you suspect hepatitis?
Dr. Anupam.
Anupam, sir, yes. Sir,
Anupam, unmute.
unmute, sir.
Yeah.
Namaste, Nitin Bhai, Ramesh, Ashay, Malti, the team, Dr. Jalil, Dr. Datta, and everyone who's joined from across the country. First of all, I'd like to applaud you for doing this for 10 years, and the fact that this is 12th this year, and the fact that you have people from 9 to 10:30 p.m. So clearly the content is very well curated, because these days attention span is limited to 10 to 12 minutes. So the fact that you have people hooked on for 90 minutes is truly remarkable. A great, very simple case, but a case that everybody sees in day-to-day practice. And I think just elaborating on Malti, this is a clinical diagnosis, but sure, you have to confirm this. So what we need to do is we need to do an LFT. I mean, clearly the stools are pale, the urine is dark, so we know we have cholestasis going on. So there's something going on in the liver. Could be obstructive also, or could it be simple plain viral hepatitis or any of the other forms of hepatocellular injury? So we do an LFT. Now, LFT means different things to different people, but what it should definitely have is a total bilirubin and a direct bilirubin. And here we will have direct bilirubin, which is high. ALT and AST should be measured, and these would be high in hepatitis. Alkaline phosphatase have very limited utility in this kind of presentation, as does gamma GT, but a complete LFT includes a gamma GT and alkaline phosphatase, because when they are increased, then you think of an obstructive pathology, and something that should be a part of the LFT if you want to call it complete. And very importantly, an albumin should be a part of it. Now, in an acute viral hepatitis, the albumin will be normal. But if you're dealing with a malnourished child, then the albumin could be low. We also have to realize that albumin is an acute phase reactant. But very importantly, if the albumin is low and you on examination find features that would point towards perhaps an underlying chronic liver disease, it's very important not to miss that, because all of us have seen situations where an acute viral hepatitis or an acute viral hepatitis like presentation is over an underlying Wilson's disease or autoimmune hepatitis, and these kids can run into very serious trouble and arrive at a much later age, finally, when they have portal hypertension, cirrhosis, or liver failure. So extremely important to have a comprehensive LFT as a baseline and just leave it at that. Prothrombin time is an important test, and if you're doing a blood sample, prothrombin time just tells us again about synthetic function, tells us about if this child is going towards acute liver failure. See, conventionally, all of us have relied on encephalopathy. Now, encephalopathy, firstly, is not easy to clinically make out in children. And secondly, before encephalopathy develops, you will get a derangement of prothrombin time. So if prothrombin time is deranged, this child is likely to get into trouble. In fact, the new definition of acute liver failure says an INR of more than 2 without encephalopathy, or an INR of more than 1.5 with encephalopathy. So one blood test that we believe is very important is doing a prothrombin time in addition to an LFT. We done a survey across several cities a few years ago, Delhi, I think it was Kanpur, Lucknow, and Pune, and we'd asked general pediatricians on what tests they do. And what was very interesting is that ultrasound came up very high. 50% of pediatricians get an ultrasound done. And honestly, it has very limited utility. All of us have seen ultrasound, it just shows some gallbladder edema, and really not needed. So if one test that we can avoid in this clinical setting is an ultrasound of the whole abdomen or upper abdomen, because it has very limited utility.
Anupam,
I'll
can
stop
I
there.
summarize to say that if you have a non-sick child coming like this
Yeah.
in OPD who's otherwise okay, you're not admitting him,
Yeah.
so decide to do only bilirubin, SGOT, SGPT, and then follow up. And if it deteriorates, of course, you would need hospitalization. You can carry on with the entire
Yeah.
LFT because
Yeah.
cost is an issue in many rural parts.
Sure,
Right?
absolutely.
So,
I mean,
yeah,
that would be fine, but just keep a low threshold for a prothrombin time.
yeah,
Because
exactly. Correct.
that gets deranged long before encephalopathy sets in. So just keep that
Absolutely.
in mind,
Agree.
and that's where one can stop.
That's
Yeah.
why I think
Thank you.
now we don't want to use the word LFT as a broad. I think Anupam will
Correct.
agree. It's a misnomer because it's
Hmm.
everything doesn't check the function. It's
Yeah.
only the bilirubin, albumin, and prothrombin time. OTPT
Yes.
just tells us about the injury. But Anupam clearly stressed for a prognosis, it is only the prothrombin time and albumin. So by chance, if you have taken the blood, I think we should do prothrombin time and albumin also. What do you think, Anupam? One poke you've already done.
Yeah.
Yeah. I mean,
Okay.
and
Sure.
it's not too expensive.
Expensive. Just adding
It's
those two because those two
yes.
are the most important functions, synthetic function and function. So,
And you're
mm,
going to save money from the ultrasound anyway,
and the
which
Sure.
prognosis that you know, even if you have 8,000 SGPT, we are not worried. We
yeah,
are not worried even if it's 3,000, but we
correct.
are
Correct.
worried if albumin is low. So,
And the
what
Yeah.
will
prothrombin
we
time
do?
is deranged.
If you are poking, do the other two.
So
Okay.
very, very important
Let's
advice
proceed.
to,
Let's proceed. Let's
yeah, so
proceed.
very important advice to practitioner that to go for albumin and PT along with LFT. Right.
Yep.
Now, Malti ma'am, again, which viral markers to subject to? I will straight away go for all three markers, or commonly hepatitis A is there. So first go for HAV.
I think Dr. Nitin divided this. If this child is admitted or not admitted, if it's not admitted, I will not do any marker or anything. But if I'm admitting, I might do. But HbA1c alone, I'm not going to do anti-HAV IgM and anti-HAV IgM for a routine child. But suppose the child is having atypical manifestations. Suppose I feel the liver is firm or the albumin, then I will do whether there is a superadded A and E. Otherwise, it's not going to change my management. So if you ask me one virus, I may only do HbSAg.
If I can add, like suppose in an OPD setting, the patient has not received any hepatitis vaccine, neither A nor B, and you're now worried that the parents say, no, I want now vaccines. So if you've done an anti-HAV hepatitis A, and if it's positive, there's no point in giving them the vaccine, which will save a lot of money because the vaccines are expensive. So from that point of view, it might be worth, but from otherwise clinical
Only
judgment
thing
point of view,
is,
yeah.
when we make a diagnosis of Hep A in a child, Hep A is the only one which can be transmitted from child to child, unlike E. So we ask whether they have an elder sibling in their house. So at least immunize them.
Correct.
That
As a
may be a
post-exposure.
reason for helping
Absolutely.
rather than for the child. It is for the others who are at home who can, because one child may be going for the +2 exam, for the board exam next thing. So that child we can immunize.
Sure.
Excellent. Excellent. Now, Akshay, a very interesting part is treatment, because there are so many treatments from Tulsi Ki Mala to liver tonics to B complex to bed rest to fat-free diet. And
Right.
I mean, this needs a somewhat detailed elaboration, because
Right.
ultimately what we do is treatment.
Right. So I will divide my treatment in three parts: medical management, counseling, and watch for a red flag sign. But let me tell you, there are more don'ts rather than do's. So first, I will go with the don'ts that do not scare the parents. We need to ensure them the natural history, the course of hepatitis A. What we see is, do not stop oil and turmeric in diet. Do not give excessive glucose water or only excessive juices. On the contrary, the liver is suppressed, we need more calories. Do not give unnecessary IV fluids or admit the child for a prolonged time. And do not do frequent LFTs. Many times we get a reference and we say, Saab, आज SGPT 1000 है, कल 3000 हो गया है. But if the INR is normal, I am not worried about the liver. What Anupam sir and Malati ma'am already elaborated. These are about the don'ts. And what we need to do is we need to counsel the family regarding the natural course of hepatitis A. We need to encourage the oral intake should be taken. But if the child is having persistent vomitings, then we need to admit the child, give a bed rest, and give a IV fluid and this medications. We also need to tell them to follow a proper orophycal hygiene, and we need to be alert. We have to advise them for the red flag signs, like if the child is sleepy, if the child is having persistent vomiting, if the child is developing fever. Usually in acute viral hepatitis, there will be a disappearance of fever and appearance of jaundice. If there is any appearance of fever, then we have to look for an eco-infection like a salmonella typhi or a dengue type of a picture, because dengue is also the thing where the liver is involved. And repeating LFTs in a irrespective of time, it has no role. So
Yeah,
simple.
that we are going to take later. Yes, yes.
Yeah, so it should be, and bed rest, IV fluid if hydration is not proper, only simple paracetamol for fever, a big no to NSAIDs, and a big no to herbal supplement, what we typically call a syrup Live 52. It
No,
has
let's not take brand name. Let's not take brand
Right.
names. Yeah.
So herbal supplement are not to
Yeah.
be
Okay.
promoted,
All right.
only this B complex.
So as I understand, you're saying to let the child eat and drink what he wants to
Yes.
within the symptomatology. Don't force him too much. Maybe a little rest for the first few days when he's sick, and admit SOS and nothing else. Right?
Avoid constipation.
With constipation. Yeah.
Passes more, because if they don't pass motion for 4 or 5
Yes.
days, you find ammonia going up and they'll become
Okay.
going in. Yes.
That's a nice point. Okay. Go
Yeah,
ahead.
yeah. Now, Anupam sir, this is a very interesting thing that sometimes patient after 3, 4 days they come with bilirubin report. Sometimes pediatrician subjects that child for repeated investigations.
A little
So,
louder, Ramesh. I
yeah,
can't hear you well.
Anupam sir, about follow-up investigations reports. Many a times patients themselves they bring with these reports of serum bilirubin that sir itna bada itna nahi. So, what is your precise advice for repeating the investigations, RFT?
So, you examine the child clinically and see how deep is the jaundice, unless, if it's a follow-up and unless the jaundice is really deepening considerably, there's nothing really in terms of repeating these tests. You wait and watch. Typical course 3, 4, sometimes 6 weeks. In 6 weeks, definitely the illness would be behind us. Of course, there is a small proportion, um, you know, give or take 10% to reported up to 20% where you can either have a relapse or you can have a recurrence. The vast majority, it's, one simple illness, and then, things get better. So you don't really have to document,
Correct.
that the LFT has come down to normal. But what you need to document is that if there was hepatomegaly, is the liver shrinking? Because sometimes, and that's where I think again, we worry about is there underlying liver disease that is missed? Because, every week we see patients where something else that was going on got missed because, the jaundice started to clear and then nobody really palpated the liver and found that the liver was still enlarged or the liver was firm. And that's really where you have to think, hey, listen, this might have been acute hepatitis, but is there something else? And do I need to investigate? And we feel very sad when we see Wilson's and autoimmune hepatitis progressing to chronic liver disease, cirrhosis, developing portal hypertension, and sometimes we've had to even transplant them because of the stage at which they come. So please examine clinically, make sure that liver shrinking back to normal, it's not firm. And if, of course, the jaundice is persisting, then please do an LFT and then think about whether we need to investigate or not. But in a classical, simple case, there's no need to do serial LFTs and track, it was 1,000, now it's become 800, it's become 200. It takes its time. It's going to take a few weeks. So there's no point rushing, doing repeated tests every week, several times a week.
So in most cases, no, when
Yeah.
the child is recovering that. Now, Anupam sir talked about relapsing hepatitis, Malti ma'am. So can you throw some light on relapsing hepatitis?
Relapsing hepatitis is an entity seen very peculiarly to hepatitis A infection, seen up to 2 to 10% of Hep A. And what it means is the initial jaundice will recover, definite recovery. And then after the recovery, after a period of 4 to 12 weeks, another spike, jaundice comes. During that jaundice, there is actually again the viral shedding will be there, the elevated transaminases will be there. So it will look as if it is another disease, but it is the same hepatitis A, and this is very peculiar to hepatitis A. So recovery, complete, a definite recovery. It's just not coming down, not a yo-yo phenomenon which we talk about, but a definite recovery, a gap of 4 to 12 weeks, and then another episode of A.
Yeah.
Okay, fine. Nitin bhai, anything?
No, that's it.
Okay. Now Ashay, what is prolonged cholestatic hepatitis and how do you manage it?
Yes, sir. So prolonged cholestasis is one of the atypical manifestation of hepatitis A, and prolonged cholestasis is defined as when the jaundice is for more than 12 weeks with pruritus and bilirubin level more than 10 milligram per deciliter. Usually, it is a deeper jaundice, intense pruritus, sometimes disturbing the sleep, and usually these are the children who present till more than 10 years of age. And if you have encountered a prolonged cholestasis, the early key is to recognize this clinical cholestasis. And usually, what we have seen, Malti ma'am and Anupam sir will agree that when this child are in clinical cholestasis phase, usually they do not develop acute liver failure.
But they are quite symptomatic because of pruritus.
Yes.
Can you help with some short course of steroids?
No, sir. So for the prolonged cholestasis, the for the management again is a year in acute simple viral hepatitis. There was first was parental reassurance, year parental and a doctoral reassurance. No restriction of diet, use of UDCA with 15 mg per kg per day for at least 2 to 3 weeks, and for pruritus, it is so severe that we need to treat this pruritus, and that we can do by rifampicin. And I would like to say a rifampicin alone is safe even with a high bilirubin and high SGPT. And there is no role of steroids because it will do more harm to in hepatitis A, and it will mask the underlying features of autoimmune hepatitis or something, any chronic liver disease. So no role of steroids.
Okay.
Now, Anupam sir, most of us we feel that hepatitis A is a simple illness and it will pass on its own within 1 or 1.5 months. But how common is fulminant hepatitis A?
The acute liver failure due to hepatitis A is in less than 1% of cases. But it's a disease where nobody should really get into trouble, develop acute liver failure, either die from it or need a liver transplant. So although it's less than 1%, well, it should really be zero.
Sorry to interrupt you, Anupam, but of the fulminant hepatitis, how much percentage is hepatitis A? Now that B is a routine vaccination and that's going down drastically.
B doesn't really cause acute liver failure in children. So I mean, out of our 115 acute liver failures that our team looked at, 17.4% were hepatitis A. Now that could be
17.4.
skewed because we are obviously a referral center,
Yes.
so we will see the worst cases where transplant is perhaps something that the doctor, the referring doctor, and the family is considering. So
Sure.
17% of our all acute liver failure is due to hepatitis A.
And that is vaccine preventable.
Exactly. And that's really sad. And when we have to transplant someone with hepatitis A, we feel terrible about it. Like just 4 weeks ago, we transplanted a girl who came in from Aligarh with acute liver failure in
How old? How
encephalopathy.
old?
She was 7.
So see,
And
that's what, even in Mumbai today, there are, I won't name them, but there are some reputed pediatricians who believe in waiting till 10 years, let the viral hepatitis A happen naturally, otherwise give vaccine. I think it's all rubbish. If you
see,
have a
the
single death,
seroprevalence has totally
yeah,
changed.
absolutely,
And you're not going to get natural immunity even at the age of 20.
absolutely,
So you're
absolutely.
going to have to vaccinate because that's a part of economic development. You know, the
Yeah,
better the economic situation, the better the sanitation, the less the likelihood of getting an asymptomatic infection at a very young age, which
yeah,
will go unnoticed but will provide you with lifelong immunity. So this child came to us with encephalopathy grade 2, deteriorated INR was 6. We transplanted her the next day. I mean, the family had zero resources. We were very lucky that, you know, we have a lot of resources now. So 2 phone calls and we got the money we needed for a transplant. The child went home on day 16. But
correct,
this was totally unnecessary. This child needn't have gone through all this. And now this
correct,
child will remain on immunosuppression for life. Without a
correct.
liver transplant, acute liver failure, the prognosis is poor. I mean, 50 to 60% of these kids will
And
die.
that too in the best of the best center. In the average
Yes.
center, it may be even higher.
Though, of course, you know, with improvements in our management of acute liver failure, which we will not go into, but now with plasma exchange and, you know, CRRT, definitely the prognosis has improved. But after transplant, the survival figures in our program are 85% for acute liver
Perfect.
failure, which is lower than what, because we are now at about 94% survival for chronic liver disease, and 85% is what we have for ALF. But
Perfect.
again, a vaccine preventable disease where no one should
Yeah.
have to undergo a transplant is the message.
So country like ours shifting from high endemicity to intermediate, you expect more outbreaks in the adults because they get more
Yep.
severe disease. And if they have not taken vaccine as a child, I think it's a crime. Like
Yep.
pediatricians are blamed for giving young infarcts as a gift to the cardiologist because we miss Kawasaki's. Same way, if we have someone getting a liver transplant as an adolescent adult because we didn't give them hepatitis A vaccine, I think that's something which is not correct and we should feel shameful about. All right, let's shift gear. I think we have go to the next hepatitis because we discussed hepatitis A, which was so common. Dr. Jalil, you have a question? Yes.
This is a wonderful session. Listening to the
Little
stall.
louder, please. We can't hear you. Yeah, go ahead.
Yes, Jalil bhai, please speak.
Am I audible now?
Yeah,
Yes,
better.
please.
Yes, better. Yes.
Sir, this is a wonderful session. So thanks for Ramesh and
No, your voice is gone, sir.
that's right. Sorry.
Yeah, okay, fine.
Number
I
one.
think we'll.
This is, I just, all the modules, all the interaction I used to ask about the GCT. Many labs they don't give, but you are stressing on INR, which is cheap and best. How best the merit of GCT versus the INR in assessing the security or in assessing the progression of it?
If you don't have INR, you should change the lab. I mean, there is no reason why anyone should do a PT without an INR. Just
No,
change the lab. Just change the lab or refer.
BTCT will not help
Yeah,
for.
absolute. BTCT is a completely given up investigation world over. It is a waste paper basket.
For the liver, you have to use only that, doctor. And I
Absolutely.
think it's universally you
Jalil
have to use only.
Jalil sir, you
Yeah,
switch off
yeah.
your video because
Okay,
your
I
audio.
think let's proceed. Let's proceed. No,
I
so I
let's
think
proceed to another case.
because
Jalil sir.
we are running out of time. So PT is the gold standard and INR is the gold standard. And if a lab is not reliable, change the lab. Let's move, Dr. Anupam.
Yes, Nitin.
How common is hepatitis B as a cause of acute hepatitis in children? You know, I mean, newborn, so they don't get any symptoms, they become carrier to adults. A lot of them in between adolescents.
So, you know, hepatitis B acute presentation is very uncommon. And, you know, perhaps what 5% of children who get hepatitis B will have an acute presentation. Obviously, with vertical presentation, you know, it's totally asymptomatic and it only gets picked up because the mother is positive. And unfortunately, it's a difficult condition to treat because, you know, the virus really becomes a part of the body of the baby, and so we struggle
Yes.
with getting rid of it. If you get acute hepatitis, you're more likely that your body will fight it and get
recover.
rid of it, but it's uncommon
Correct.
and compared to adults. So that's something to be kept in mind.
So younger the age, less immune response, so they don't develop acute hepatitis, but more chance of chronic carrier. Like a newborn has a 90% chance of chronic
That's
carrier
right.
state without any acute hepatitis. An adult has 10% chance of carrier rate and more chance of acute hepatitis and
Absolutely.
recovery. So I think that's a fair equation. So Ashay, this question is asked that if I delay birth dose hepatitis B, everyone is at home, are okay, they're okay. Can the child still get hepatitis B? So I mean, is the vertical route the only route in a small baby, or the other like horizontal routes and other routes? Of course, blood and sexual is completely different, more for specific disorders like blood transfusion dependent conditions or an active, sexually active adolescent. But generally, in a small child, what is the role
Yeah.
of horizontal transmission vis-a-vis vertical transmission?
Mainly in our pediatric, it is mother to baby, what we called perinatal transmission, and other what you elaborated, it's a blood products, sexual contact, or multiple blood transfusion requiring children are at a higher risk of getting this hepatitis B.
Correct. So, two things. When we used to deal with hemato-oncology and thalassemics, lot of them were hepatitis B positive before the vaccines were available. And we knew that if children who run around with blood collection and they are, touching the bleeding side and things like that, and there were very high chance of cross-contamination. So that was a very classical horizontal transmission. And many of these children would not even respond well to vaccination because they're immunocompromised when they are multi-transfused. It was really a task to manage these children. Horizontal route is an equally important. That's why you should not delay the birth dose. You presume, because it is proven that if you have a hepatitis B carrier in a family, then for other family members, especially children, of chances of becoming hepatitis B carrier without mother being infected is 6 times more than in a general population. That means there is a lot of horizontal transmission happening. Okay, so that brings us to that, Dr. Malti, that Dr. Anupam spoke that younger the child, more chance of become carrier. What is the hepatitis B carrier, and really what happens to him over long, say 10, 20, 30 years, 40 years?
Yeah, I think, thank you, Doctor. The term carrier is now not preferred since,
Correct.
like all of us, you listen to the word carrier, you assume that they'll only carry. They will not get the disease and they'll only give it to others. So
Correct.
you also take it lightly, they will also take it lightly. But we should remember that hepatitis B infection is, hepatitis B virus is a very dynamic virus. Any point of time, the inactive can become active, because what happens is when the virus enters our body, it gets integrated into the liver
Genome.
hepatocyte and gone. cccDNA has gone, it has already got integrated. What you're seeing outside is what we are talking about, the carrier state and all that. So once it enters, it's entered. So any point of time, so that first thing we should forget is it's thing. So what did we call carrier? We called it carrier when they had a low viral load and when their transaminases were normal. So
Correct.
any point of time, we know they can change. So now what terminology we use only two. We see whether they are EAG positive, whether they are EAG negative. Next, we look whether their transaminases are more than twice upper limit of normal or less. So if the transaminases are less than twice upper limit of normal and the DNA is, we just call it as an infection. The child has an infection at present. It does not have hepatitis. You don't need to treat that child now. Any point of time, this child can come into a hepatitis. It can become, you may have to treat the child. So that thing should be in
No,
the
so,
mind
so, so
of,
what's the natural course? Like, suppose nothing happens to the child, can he overcome that
yeah,
only
this
HbSAg
what there
positivity?
is a post course what is known as the spontaneous seroconversion, which is higher in certain countries depending upon the way they've got it. The younger they are, they don't think. So if it's a vertical, it takes a little longer time. They may not, but spontaneous conversions have been reported. But best is to follow them up and treat them.
And
If
what
we
percentage would actually progress to actual disease or
chronicity,
chronic
yes. So
diseases and
suppose
need what
that's why
percentage?
we get zero. Suppose they get it at birth or less than 1 year, their
Mm-hmm.
chances of 90% going for chronicity. But the age of 5 years, after that, it's only 5 to 10% will go for chronicity.
Correct.
And that was the reason why the zero vaccine, a zero dose vaccine has been thing. The
Perfect.
earlier we have
Perfect.
to give.
Perfect.
That's all.
Yeah, Anupam. Now, what tests would you like? You have HBsAg anti-HBsAg antibody. You have E antigen. You have E antibody. You have C. You have core. A lot of confusion and different stage of hepatitis B disease pattern will have a different types of positivity. So, in a given case, what are the minimum tests you do and how do you interpret them?
So, Australia antigen or hepatitis B surface antigen to confirm the diagnosis.
Perfect.
Hepatitis B core IgM will tell you that it's a recent infection.
Correct.
Hepatitis B E antigen positivity will tell you that what is the kind of replication that's going on. And you have the HPV DNA, which gives you the exact level.
Correct.
These are the ones to be done. Where what we want is we want the DNA to go off, so the level to decrease and then to go out of the body. We want the E antibody to become positive, which means
Correct.
that the active replication has stopped. And the ideal goal is for the child to become hepatitis B surface antibody positive, which we might or might not be able to achieve with medication that we have.
Correct.
So that's really
So,
the sequence.
correct. So you do an HBsAg and an E antigen. If it's E antigen, he's replicating, follow them up. If you convert to anti-E, you are happy, and then you follow them up still with LFTs and things like that.
Yeah,
Is that
but
the correct
it's
approach?
also you need to do the DNA, but on a core IgM, which will tell you that it's an acute infection and not chronic. But it's extremely important that hepatitis B is managed in specialist hands because it's not
Correct.
all that simple. And
Absolutely.
there are just too many variations, and also the therapy is prolonged, and it keeps evolving. There was a time when we used to give interferon, then we moved to pegylated interferon, then we moved to
Correct.
lamivudine, and then adefovir, and now, we use entecavir and tenofovir. So this is
Absolutely.
treatment that's evolving. It's
We'll
not
come to that.
ideal. It's not
Yeah.
ideal,
Yeah.
and therefore it's best handled with by
Sure.
specialists.
And it's a thought that HBeAg is non-replicative and it is mild should go off also from our mind.
Correct.
EAG negative indicates it's a pre-core mutant infection.
Correct.
So they will not respond to treatment also properly.
Right. So Ashay, I mean, we spoke, Dr. Malti spoke, Anupam spoke that hepatitis B surface antigen positive is just a starting point to tell you that this fellow has hepatitis B. Now he will progress, he will not progress, he may recover, seroconvert, etc. All will know only when you follow up. So a
Right.
child who say HBsAg positive today, for some reason someone has done an HBsAg. Now parents want to know how frequently they should do LFT, when do they do viral load, when do they do this specialized antibody like E antibody, etc. I mean, how do you go about it in a practical manner?
Yes. So before monitoring this, we should be clear in our mind about the five things that virus DNA should disappear. It is our goal.
No, when
Surface.
do you do it first? That's the question.
Okay. Okay. So
That's
first
the
you have
goal of
child.
treatment. We are not
Okay.
discussing treatment. We are discussing the parents want to know how bad is my child's
Right.
condition and
Okay.
when do I come back with the what investigation next?
Right. So first, if you have a child with a newly diagnosed hepatitis B, then we'll do of SGPT, that is ALT, alpha fetoprotein, HBe antigen, and anti-HBe. If there is a history of any liver disorder or HCC in family, then we also do an USG abdomen.
Correct.
Now, if HBe antigen is positive and SGPT is normal, then we'll keep the child on a regular follow-up. We'll repeat SGPT every 6 to 12 months along with alpha fetoprotein and HBe antigen and anti-HB antibodies.
So every 6 to 12 months you will repeat
Yes.
those tests. All right. When will you do your first viral load?
First viral load when you have already confirmed when HBsAg is positive, when you have HBe antigen positive, then we do an HBV DNA, HBV DNA. And if HBV DNA is less than 2000 or 20,000, depending on that, we'll think nowadays we don't call it immune tolerant phase. Nowadays we call it a chronic infection and a
Correct.
chronic carrier.
Correct. All right. So generally you do it 6 to 12 months in between. If the patient deteriorates, then you would do it more frequently to take
Yes.
your decision as to when to intervene and treat the patient.
Yes.
All right. So Dr. Malti, there were terms when we were students where use chronic active hepatitis, chronic persistent hepatitis. Are they all gone or what do they indicate?
No, these were more used by the pathologists to show that in persistent hepatitis, all that they meant was that the inflammatory cells were confined to the portal area and that they didn't spill out. Active hepatitis, the inflammatory cells spilled out through and they were coming into the parenchyma and was causing bridging necrosis. So they are the ones which will go for fibrosis. Now they have a little different way of doing the histopathology. They give us what is known as histological activity index. So they have a score for everything, and they tell us if it's more than 3, then we treat even when it's what he called as immune tolerance or that. So it is an indication that the child is progressing. So they have scoring points. So those terminologies have changed, but what they look in is the same. They're looking for inflammatory cells in the portal tract. They're looking for bridging necrosis. They're looking for fibrosis. They're looking for that. But they all have standard universal scoring.
So when would you do your first liver biopsy?
Liver biopsy, we will not do during the acute phase. In any
No, not
time
acute
when
phase. Patient
chronic,
is
if the liver is firm and we are not sure whether to treat or not to treat, but there is a family history of liver disease, it's always better to do a liver thing. But now, since we have the fibroscan, which seems to be a less
invasive.
invasive, we can get fibrosis to some extent. But as pediatricians, we always prefer a liver score. Yesterday, I took a class. Anupam's patient, I know that thing, beautifully they had done a transjugular, and only because of that liver biopsy, they could prove a child with hepatitis A having autoimmune hepatitis.
Correct.
6th week, child not improving, I think very nicely they had done and showed. So if you feel that there is some atypical manifestation, there is a prolongation, you are having a firm liver, albumin is dropping, you feel the treatment has to change. Only then, don't do it just for diagnosis. Something in the treatment should be there. Then you can do a transjugular if your prothrombin time is prolonged, or give the regular thing.
Sure. So I think that brings us to the main question, Anupam, and that's when do you treat? Before treatment, what are the things that you look for? What drugs you use and for how long? And what is the prognosis ultimately of the treatment?
See, treatment for hepatitis B in children still, we haven't really achieved the levels that we have with hepatitis C where we can actually achieve a cure. So the good thing is that we don't have injections. The good thing is that we don't have medication where, each time you give the injection, there would be side effects like with interferon, fever.
Correct.
And it was a very difficult proposition for families. And pegylated interferon got a little better. Then we got oral
And
medication
expensive.
like, yes, oral medication like lamivudine, easy to give, but then lots of resistance and entecavir.
Correct.
So finally, we are now on entecavir and on tenofovir. So the advantage with these is oral. How long do we have to give? We don't know, might even be lifelong, but it's definitely for an extended period of time. I think as our knowledge improves over the next few years or we get breakthroughs, one can say with satisfaction that our therapy has improved considerably, but far from where we want it to be because you really don't have an end point in terms of
So
when you
it,
stop.
it just prolongs the ultimate transplant, or it
No,
actually
it,
is sort of
as long as you keep things under control, as long as there's no replication, there's no damage, there's no fibrosis, cirrhosis will not develop. Hopefully, hepatocellular carcinoma will not develop.
And
So
how expensive is this treatment
yeah,
on a
I mean,
monthly
it's not
basis?
that expensive, a few thousand rupees. I mean, it's not cheap, but a few thousand rupees compared to what it would be with interferon or what it is
And how
overseas.
do you follow up them to see for
So
response? Like you do your
you
viral
follow
load
up
or you do
as
liver biopsies?
you don't have to do serial liver biopsies. You follow them up with the DNA to see what's happening, and then
Mhm.
eventually you wait for seroconversion. So your DNA disappears and your E antibody becomes positive. That's
Correct.
what your aim is. I mean,
So if some,
ultimately, we want the Australia antigen to become negative and surface antibody to become positive. But like I said, that is not likely to happen
correct.
currently with the kind of medication we have. It will happen in a very small proportion of cases.
So let me say, if you have say 100 such children who are HbA1c positive, they have heredity which are abnormal over the time, you think now you need to intervene, you did a viral load, they were positive, so you treated them. Now out of the 100 you have treated, how many would seroconvert to an anti-HbA1c, which is your final goal? How many will convert?
Hardly
Okay,
ever.
hardly any. How many will convert to anti-HBE to suggest that replication is
Well,
stopped?
the E antigen becomes negative
That's
in significant proportion, and then over
significant.
a period of time, the E antibody becomes positive.
So that's what
So,
in 40, 50,
I mean, we have to
60%.
realize that entecavir and tenofovir in children haven't been used for that long. They were not
Correct.
licensed till very recently.
All right.
And with interferon, we had something like 20% success in terms of getting the E antibody conversion. But
Only.
yes,
Oh.
and that was like considered as reasonably successful. But I think with these two medications, clearly we will have better response rates, but don't really have much data also, they, like I said, been licensed for use in children.
Too short, yeah.
It's too short. We all acknowledge that a vertically transmitted hepatitis B is a challenge because the body does not recognize it as foreign. So it's very hard to mount an immune response. It's very hard to get rid of that virus.
Correct.
So therefore, we cannot overemphasize the importance of hepatitis B vaccination at birth. We have a
Absolutely.
safe vaccine. It's been around for nearly 40 years now. And we really have to use it, and no child should miss the 3 doses of hepatitis B.
Perfect. So, I mean, what do you think the transplant requirement for hepatitis B in general in pediatrics is coming down after the
But it was
national
never
program?
significant. It was never significant,
Oh, is it?
hepatitis B as an indication, because this is a slow growing
No,
problem.
so may not be in pediatric, but others like you,
Yeah, I mean,
like
adults, hepatitis B, definitely. Hepatocellular carcinoma, definitely. Hepatitis C was the commonest cause for, commonest indication for liver transplantation
now.
in adults, but now it isn't because we have a cure.
Correct.
So hepatitis B, if you look at the caseload, will become more important than Hep C, because we still have a fairly large pool of hepatitis B patients on the adult side who've had
Correct.
it for 20 years, 30 years, 40 years. And
Correct.
they are at risk of developing hepatocellular carcinoma or cirrhosis.
In fact, they did the initial studies of hepatitis B vaccine and the impact it will have on the chronic liver disorder, because hepatitis B was in Taiwan, which had a very
Yes.
high carry rate of 8 to
Yes.
10% in the
Correct.
community. And they
Yes.
started the national program, and in 10 years, the HBsAg as a cause of fulminant hepatitis and needing transplant disappeared, and in another 10 years, the hepatocellular carcinoma disappeared. So that could be the powerful impact. So that brings
Yeah.
me to the vaccination. So we discussed vaccine, and Ashay, universal immunization. First, we started targeted immunization, it failed. Then we say only high risk, it failed. Now universal.
So, sir,
It's so cheaper vaccine. 45 rupees is the MRP. Why
Yeah.
should anyone not get it?
Exactly. So, sir, universal hepatitis B vaccination, it is already there in our national program.
Correct.
Looking at the safe immunogenicity of the vaccine and high transmission rate of all the dreaded virus and its
Correct.
potential to cause the what we call typically a chronic liver disease and a hepatocellular carcinoma, I think we should have a universal hepatitis B vaccination. And you must be knowing more than me well that CDC has also recommended to be given in all the
Yes.
adults from 19 to 59 years old and after 60 years also with a high risk
Absolutely.
cases.
Absolutely. So two things. Standalone hepatitis B is in shortage in the country. It is so pathetic that you don't have a neonatal hepatitis B vaccine available in a lot of part of the country. Now, fortunately, one of the companies has come back with this hepatitis B standalone. So hopefully it should improve, because I'm worried that a lot of people, a lot of babies can get infected at birth if they don't receive the hepatitis B at birth. And those, I mean, though 98 to 99% of these children will respond to hepatitis B vaccine, there are some primary non-vaccine responders. And there's a good news, because there are two more new hepatitis B vaccine, what are known as PreHevBio and HepliSav. And this HepliSav has some pre-S1, pre-S2 component, which actually was there in the plasma-derived vaccine when we were students. That had pre-S1 and pre-S2 as a contamination, just not pure as antigen. And that leads to pre-S1 antibody, pre-S2 antibody, which will also help to them if they cannot mount an anti-HBs antibody response alone. So there is always a better vaccine available. But remember, if you take this vaccine before 40 years, your chance of seroconversion are very high as compared to after 40. And obesity and smoking, these are the two enemies of hepatitis B vaccine program. If you are a smoker and if you're obese and if you're above 40, less than 60% chance that you will seroconvert in spite of the vaccination. So I think we will end that question about the explanation. Now let's, Dr. Malti, newborn born to HBsAg positive mother, quickly.
Yes, quickly
What do
we
you
have
do?
to give both passive immunization, HBIG on one thigh, 0.5
Yes.
ml, and give the active
Correct.
also on the same
Correct.
day. Preferable
Yes.
to give the passive, if you give within 6 hours, very good, at least 12 hours, but not later than 7 days.
Perfect.
Practical is, if the mother knows, ask her to buy HBIG and keep it in the place where she's go for delivery rather than running
Yes.
at that night. See, they have to
Absolutely.
be prepared. I think that's very,
Yeah.
very important. We have to
And I
stress
think
that.
the big NIC should have stock of hepatitis B
Or
immunoglobulin always with them.
the individual should be aware of that and buy the
Yes.
vaccine.
Yes, right. And follow them up with the 3 doses of the infant
Yes.
program at 6, 10, 14.
016.
Yeah.
Even then, like you said, they may not 5 to 10% may not zero convert.
And when
And
would
that
you
is
When would you
That's
check for the HbSAg to see that your prophylaxis is effective?
no, I
A
think
month
we
after the last dose?
don't do that. 6 months later, you can do, but
6
we
months
don't
later.
check. But this is why this antenatal antivirals have started coming, sir.
Okay,
It
okay.
started at 28 weeks for the mother.
Malti ma'am,
Yes.
is there any revision in change 0.5 ml to 1 ml?
Yes, yes, you can, depending on the weight, and they've said 0.5 to 1. You can make it 1 because the volume is the reason. So you can give 0.5, 0.5, or give 1 ml one thigh and then give the vaccine the other side.
All right. So Anupam, most problematic needle stick injuries. HbSAg carrier person, someone gets a needle stick injury. How do you go about?
First of all, every institution to take every precaution in terms of preventing needle stick injury. So there should be a clear policy on how do you prevent needle stick injuries? How do you train your staff? Do you have all the resources available? How do you dispense the needles? You don't go around trying to remove the needles from syringes. Disposal, extremely important, and this training needs to
Absolutely.
happen repeatedly.
Prevention, right. But if
One.
suppose it
And
happens.
you should have a very clear protocol on what should be done should someone get exposed. So now, what you are saying here is that the person has been exposed to someone who is actually hepatitis B
Yes.
Australia antigen positive. So the first thing to check is, of course, has this individual, let's call him recipient for a moment, has this recipient been vaccinated or not? If the individual has been vaccinated, great. Let's look at the anti-hepatitis B surface antibody titers, and if they are more than 20, definitely definitely more than 10, 20 is even better. Good.
They are protected.
Yes.
Yes.
If not, we would not take any chances and start
Yes.
vaccination and give immunoglobulin at the same
Okay.
time, because you really do not want this person to get infected.
Absolutely.
Give the 3 doses of the hepatitis B vaccine and give the hepatitis B immunoglobulin at another site. And hopefully this will result in prevention of the individual getting infected.
So 0.06 ml per kg in a
Yeah.
80 kilo person will become 5 ml.
Yeah.
2.5 ml on each
It's
side.
inexpensive.
Extremely expensive, very painful. I would always say that if you have taken hepatitis B vaccine as a doctor, always do your titers at the end of the third dose. If you have seroconverted any time in your life, even when you get needle stick injury, and if your titers are 0, it doesn't matter because you have seroconverted in past, you don't need to do anything. But if you haven't checked, you don't know whether you are primary non-responder, then you'll have to take the immunoglobulin vaccine, and that's a torture. I think they should make a rule that during internship, normally these people give vaccine to during the third MBBS or internship, they should check the titers.
Now of course all of them have had it.
Yeah, because
this
the
new
birth cohort.
the new breed has had of young doctors would have had it
Correct.
at birth and as children. But extremely important to check the seroconversion. Very important. It's a simple enough test to do.
Perfect. I think hepatitis C is very rare in children unless they are blood transfusion dependent. So I will skip that because of lack of time. Let's come to the hepatitis E and the viral marker negative hepatitis. So quickly, let's run Dr. Anupam. Your experience of hepatitis E now in children? We see in adults very frequently. In children, did you see it?
Just one point on hepatitis C, that when should one test if the mother is positive, is that antibody, the recommendations was 18 months. Now with the RNA, it's 2 months. So just keep that in mind. Don't do it before 2 months. After that, do it.
So molecular diagnosis at 2 months and antibody
and then
based
follow up,
diagnosis
and then we
at,
see, and because we have a cure.
Perfect.
So that's
So
important.
this is same as HIV. You do it at 18 months. If you are doing antibody, if you are doing DNA, then you do it as early as 2 to 3 weeks. Here at 2 months. Perfect.
2 months.
Very
Now
good.
coming to
We should
E
not
is
forget the IV drug users. There are hotspots in Punjab and
Adolescents.
Northeast.
Manipur.
Very high. Manipur,
Yes.
very high. Adolescents with HCV.
Absolutely.
Remember them and treat
Agreed.
them.
Yes.
Agreed. Yeah.
Coming to Hep E, it's uncommon in children.
Can you suspect it is E on clinical ground or it looks same as A?
No. We've got a few children where we've had A and E both, and a very small, again, it's compared to A, it's next to nothing. And it doesn't seem to be a common problem in children. Of course, epidemics have been described as we know from Kashmir and other parts of the country. But outside that, we haven't really seen. But of course, when we are investigating someone who gets referred to us because the jaundice hasn't cleared, then E is also something we test for after A. but
Mm.
definitely a lot lower in the list.
So let me say this way: that someone has taken hepatitis B and A vaccine as a child. Most of them would take in private practice, and now they develop clinically acute hepatitis. Prudent to test for E straight instead of wasting money on A.
Well, again, Nitin, and
Because
you
we
know
have
this
had
better.
outbreaks in some pockets, even in Mumbai. Like we know
Yes.
someone coming from Kurla side or some other side, it's likely to be E.
Yeah, I mean it's extremely important to know if the vaccine was actually given and the booster was
Yes.
given or not, and if one is satisfied, then
Yes.
it would make sense to do E. And also, like you said, there've been cluster
Perfect.
outbreaks, so then one would look at it. The important thing from our point of view is hepatitis E in pregnancy is a very serious
Yes.
disease,
Correct.
and it can result in acute liver failure. We've actually transplanted a few pregnant ladies who've
Correct.
gone on in utero. We've had to transplant and have delivered a normal baby after transplant, but they would have
Perfect.
died,
Correct.
because of the acute liver failure. So that is, from our point of view, as pediatricians, is a connect that we have, but it's in a lot commoner in adults, and in pregnant ladies, it is a serious illness.
Dangerous. Yeah. Dr. Malti, is Hep E in children dangerous? Like suppose a 6 or 10-year-old child is Hep E. Is it as good as Hep A? Most of them recover almost.
I think Dr. Anupam has clearly said that usually E is a self-limiting disease only. So he's very clear. It's more what we've seen in pregnancy and the problems. Even in epidemics, they had subclinical infection. But now we see, though we say HIV does not go for chronicity, immunocompromised and those HIV positive, they may
Correct.
go for chronicity. That's what we have to remember.
Okay.
Otherwise, we don't have. I think he's very clearly told about the natural history of E in children and pediatrics.
So any case of fulminant hepatitis because of E alone or
As
E in
such,
combination?
yes, they have report. Actually, our burden in our country throughout, when they saw 100 children of ALF, depending on where they have reported, it has even
Mm-hmm.
gone from 2 to 45. In South, we don't have much, but
Uh-huh.
then there have been reports earlier. Now it seems to be little changing. But what is more important is Wilson plus E,
Yes.
AIH plus E combining with ALF.
Correct. 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 Ashay, any special test for E or just like Hep A as we
Yes,
discussed?
sir. So
Besides doing, of course, the anti-HEV
just
IgM.
like hepatitis A, anti-HEV IgM serology, and sometimes HEV RNA in serum
Mhm.
and stool. And sometimes, if IgG is positive and it is more than 5 times, we consider acute hepatitis C,
Okay. Correct.
rising
And
IgG.
okay, is this test is easily available? Is it very
Yes,
expensive?
sir. Yes, sir.
Yeah, all right. So Anupam, question. Of course, E is an enteric, like A, both are vaccine preventable, but unfortunately, there's no anti-hepatitis E vaccine, at least in India. Are
Yeah.
there any vaccine in the world scenario? Or
Yeah,
are
I mean,
someone?
there have been a couple of vaccines that have been studied, limited use for the military. In
Mm-hmm.
Israel, they've used, in
Mm-hmm.
China, but
Mm-hmm.
really limited kind of access,
Correct.
and indications are kind of limited. So at this point in time, hepatitis E vaccination is not something that we have to
Correct.
prevent
So
hepatitis E
the
infection.
hepatitis,
So
yes,
water, sanitation goes back to the
yes.
same thing to prevent
Wash.
hepatitis A, typhoid, all the enteric infections
That's
that
what your
we.
wash technique,
Yeah,
water, sanitation, hand hygiene, and safe water.
yeah,
So there is this Chinese Hep B vaccine which is licensed for above 18 years. Fortunately, unfortunately, it's not for children. Of course, maybe we don't need it for children
yeah.
because, as everyone is saying, it's not as common, and its level is excellent. I mean, almost 100% effectiveness as hepatitis A vaccine. There was some company which was trying to bring that Hep E vaccine of Chinese origin to India. I'm not sure when that will happen. So let's open the Pandora's box now, Dr. Malti. You have a acute hepatitis or a hepatitis in general, and you have done the viral markers because the patient is not responding as you would have expected, like the bilirubin going down, the urine color is going down, his appetite is improving, liver size is becoming normal, he's voracious in appetite, whatever hepatitis was there, he's recovering, but he's not recovered. And now we have done the viral markers, and it's A, B, C, E all come negative. What are you looking at?
So this is what we call is a non-A to E
Yes.
acute hepatitis. If we are very theoretically, or if you want to do, we can do for the other non-hepatotrophic viruses, because this
Like,
adeno is now becoming very
mm-hmm,
important now, especially after
okay,
COVID. we find them presenting even with ALF. I think even Apollo, they had some papers on that. And dengue virus, it can be there. It can be EBV IgM. Whenever it is prolonged, think of Epstein-Barr virus
Okay,
presenting.
right.
And then, but if there
CMV,
is CMV, yes, but not at this age, usually not
neonatal.
resting too much, but you can think about that in immunocompromised. But what you should think of will be the non-infective. Don't forget Wilson, don't forget
Drugs. Yeah,
autoimmune
yeah,
and
yeah.
drug. That would be the way we'll approach.
Absolutely. And in a child who's sick and febrile, don't miss typhoid as a cause of hepatitis.
Typhoid, leptospirosis, and scrub.
Leptospirosis.
Scrub.
Perfect, perfect.
Scrub.
So these are the things you'll keep in mind based on the clinical scenario. If your child is sick, toxic, febrile,
Yeah.
think of infection which are not A to E.
Yes.
If there's not toxic, then think of other causes like metabolic, toxic, etc. I mean, Giloy as a cause was one of the very important thing which happened in some people. So let's bring to Dr. Ashay. Dr. Anupam also spoke that if you have Wilson as a background and you have an acute hepatitis A will improve, but Wilson will not improve. So when do you suspect Wilson's disease as a cause of liver disorder? And can Wilson come as acute hepatitis?
Yes, sir. So we normally talk Wilson disease affecting the liver and brain. But we also need to remember that there could be a presentation like it can affect kidney, heart, bone involvement, and sometimes the hemolysis. So any hepatic presentation could present as an Wilson disease. Mainly, it could be any acute hepatitis which is not settling for the long time could present
Correct.
as an Wilson disease. Acute liver failure could be just in Wilson disease. Any chronic liver disease with decompensation or with a portal hypertension can present as in Wilson disease. Or
Correct.
a child who has been investigated for something else and you find any abnormality, especially raised biochemical evidence of a raised transaminitis, it could be a
Correct.
Wilson disease. And the
Correct.
most problematic thing nowadays we see when we go in ICU for a cross reference, we see acute on a chronic presentation that this
Correct.
child has a Wilson disease, but there are no symptoms. But
Correct.
on superadded, you had a hepatitis A, dengue, or a entry salmonella typhi. At this time, the child presents as an acute as well as a chronic disease. So high index of suspicion is to be needed for this Wilson disease and especially
Correct.
neurological involvement
So,
which starts with
so if you have acute hepatitis, acute on chronic liver disease, just a chronic liver disease, especially in a consanguineous family where everything is not fitting into your viral markers are negative, the least you should do is to rule out Wilson disease always as a case. I had a child of tuberculosis and we had put him on AKD, farmacy ionized, and he came with massive hepatitis-like syndrome. And the drugs were tapered, stopped, restarted again the same thing. And we said, no, why is this child reacting so badly? We did his Wilson workup and he was actually baseline Wilson. So he was reacting very badly to the hepatotoxic drugs. So that brings me to Anupam as to now that you have suspected, how do you prove? I mean, is it just the serum cellular plasmin or you do 24 hours urine copper estimation before and after Artemin challenge? And what are the ways? What is the current status? Anupam, unmute.
Sorry.
Yeah.
There are so many criteria, and scoring systems, starting with the German Leipzig criteria, and then we have the ESPGHAN, and then, the Indian Pediatric Gastro Group also published. So I would urge everyone to look at that scoring system. You have to look at it because if the score is more than 4, then you are dealing with Wilson's. And you look at older children, you look at the KF ring.
KF ring.
You look at ceruloplasmin, which will be low. Your 24-hour urinary copper will be high. You look for hemolytic anemia, and sometimes you will do liver copper, but firstly it's very hard to measure it, and secondly it's not always needed. And we also sometimes will end up doing a imaging of the brain if you have features of neurological Wilson's. So there are clearly defined criteria. So the important thing is to think about Wilson's. Once you start thinking about it, making a diagnosis is not very hard. Treatment.
So just two more questions. That do you do a post Artemin 250 milligram again a copper in urine and see these massively increases?
I mean, you will definitely see an increase if you're dealing with Wilson's.
No, so is that a standard of care?
I mean, you don't have to.
Okay. And genetic test, direct?
Genetic testing, as again, you want to do this from an academic point of view. There is a family member already afflicted. Please go ahead and do it, but otherwise it doesn't add. Like we, for example, have a family. We have transplanted 2 children with Wilson's. Unfortunately, both of them came to us late. So from that point of view, yes, it'd be nice to see what mutation you have.
Correct.
So the key here is to think of it, confirm the diagnosis, start this patient on therapy
As
and
early as possible.
as early as possible. Therapy is lifelong, and they need monitoring because sometimes parents tend to forget about giving penicillamine.
Yes.
Also, listen, there are challenges with penicillamine. Sometimes you get significant thrombocytopenia. You'll have to
So
change
is Trientine the
therapy.
drug of choice nowadays? Someone can
No, we
afford
will
it?
go
Or?
with penicillamine. It's a lot cheaper. It's
No, someone can
easy.
afford.
Yeah,
Is
we
it
will go with
is it
penicillamine and
safer?
keep Trientine as a backup. Sometimes even with Trientine, you get similar side effects. So go with
And just
penicillamine and
and
then
just
go into
oral
Trientine.
zinc in a
Alone won't work. They tend to use it in Italy when a sibling has been diagnosed
correct,
with an index case, just zinc. But zinc alone will not do the job. So you will
correct.
need proper chelation and you will need penicillamine. So we
Perfect.
tend to use a combination of zinc and penicillamine. And if we have problems with penicillamine, we go on to Trientine.
Trientine. Okay, Dr. Malti, we talked about acute autoimmune hepatitis. So when do you suspect that this could? I'm like you've done a Wilson's workup. Now you're left with what? So when do you suspect autoimmune? Like, are there any other autoimmunity associated with hepatitis where you think like someone had a ITP before, or someone had an acute immune hemolytic anemia before or after, or something like that?
Yeah, just like Ashay was saying, like Wilson disease, autoimmune hepatitis also can have a varied presentation. Acute
Mm-hmm.
hepatitis, ALF, incidental, everything
Correct.
they can have. So if
Correct.
you have extrahepatic manifestations like hemolytic anemia or a celiac disease or diabetes mellitus, or if you have some other thyroiditis, it has been
Mm-hmm.
reported, and
Okay.
especially anemia, then you can suspect. And suppose you have arthralgia along with that, and then you have a
Mm-hmm.
rash, then you will suspect clinical
Correct.
features.
So it's a
Biochemically,
multi-systemic.
system,
But
biochemically, tell me.
but it is that when they have this autoimmune acute hepatitis or a chronic liver disease like that, they will necessarily have one at least system in all, or it may
No,
be.
but there's a report from India itself where they said at least 30 to 40% had extrahepatic.
Oh, I
So
see.
maybe you have to just look at it. It may be,
Okay.
something you'll find. You'll find
All right.
something. It's
Okay.
not that
Okay.
it's complete, but you may
Yeah.
get 70% not having also, 60%
Yeah.
not having. So
Absolutely.
then your elevated transaminases, your presence of autoantibodies, and in your investigations, if you find globulin little high, just do
Correct.
IgG. And if you
Yes.
pick up hypergammaglobulinemia, that itself
Correct.
is a good clue
I think
rather than before the liver biopsy. That
very good clue.
hypergammaglobulinemia, I
Extremely
think
good
very
clue.
important.
I remember I had a child of AIHA, which I treated with steroids. He was a small child, around like 2 years old. And then after 1 year, he came with hepatitis, and we investigated. It turned out to be acute autoimmune hepatitis. And there was similar child of ITP. So that means these are related autoimmune disorders, and generally not, but yes, rarely you could have this type of
They
pictures
do
coming
have.
together. So Ashay, then if you have suspected autoimmune hepatitis, how do you prove it? I mean, what are the antibodies you do, and how do you label them?
Yeah, so the antibodies are the autoimmune antibodies. What we do is ANA and SMA, and whenever we order these antibodies, we need to tell our pathologist colleague that please make the dilution in 1:20, especially for ANA and SMA. Usually, these adult fellows will start the dilution from 1:100, and that will yield our diagnosis. So ANA and SMA with 1:20 dilution, LKM antibodies with 1:10 dilution, a total IgG should be raised, as Madam said.
As Madam said, right?
And most important, to prove autoimmune hepatitis, liver biopsy is must. And we should look mainly three things in liver biopsy. We need to document: is there any evidence of an interface hepatitis,
Mm-hmm.
rosetting of a hepatocyte, or
Correct.
there is an hemiperipoiesis. And sometimes what we get are autoimmune hepatitis just presenting has an acute liver failure. And to distinguish the liver biopsy, it will tell a central perivenulitis. I think Malti madam and Sibyl sir will agree with me.
Correct.
Yes.
So that's correct. So is there a difference if suppose as someone with acute autoimmune hepatitis, DNA, ANA negative and ANA positive, does it make a change in the prognosis of the treatment part?
Yes. Usually, this it has been divided in type 1, type 2, and 3. If
Correct.
SMA and ANA is positive, we call it type 1. If
Correct.
LCM is positive, we call it type 2. But there are a few chunks where it is called type 3, but it behaves like a type 1 and it is more severe in nature. And usually by differentiating type 1, 2 and 3, it helps us to prognosticate these kids, and for a long-term treatment is more important, because these are
Correct.
kids who are going to have steroids and immunosuppressants for a long time. So
Correct.
for
Anupam, I'm sure it's a topic by itself, but in brief, like if you have an proven acute autoimmune hepatitis, what is the prognosis and what are the drugs you use, especially if they have had ITP or AIH in the past? What are the drugs and how long you give? Unmute.
Bad habit, I always mute because I don't want any disturbance and all these
No issues. No
Zoom
issues.
meetings that we do every day.
Yeah.
It's a good habit.
So basically, the treatment is immunosuppression. So you start with
Correct.
steroids, and
Mhm.
invariably these kids require steroids for an extended period of time. In fact, you won't even attempt trying to,
Correct.
stop steroids till the AST and ALT have been normal, like at least for a year.
Correct.
So the best thing to do is add, azathioprine, because,
Correct.
as you taper the steroids, you need some backup.
But do you
So,
continue a very small dose steroid even with azathioprine for like
you take a
ever or
call
for
for
years?
a few years, you'll have
Few
to
years.
definitely see, but using azathioprine or mycophenolate, and of
Mm,
course, sometimes you end up using cyclosporin or tacrolimus. But
correct.
basically, it's immunosuppression. The simplest combination, which does work in the vast majority, is steroids with azathioprine.
So azathioprine is much safer than the other drugs, right? And
Cheaper,
is
a lot
lifelong,
cheaper.
or can you ever stop? Like suppose you are given for 3, 4
Very
years, do a
few.
biopsy is normal.
I
Can
mean,
you
I
take a
don't.
chance?
Yeah, you can. You can always
Because parents want that
attempt.
question, the itna chota bacha hai, you are saying lifelong azathioprine. Can I not stop
No,
and
you
see?
you
And
you can. I mean, and again, like we don't quite fully understand who's likely to not
correct.
get into trouble. So it's worth
Mhm.
trying, but quite often when you start tapering, only the enzymes start to go up, and that
Correct.
gives you an answer like this kid is going to get into trouble. So
Correct.
frankly, in our experience, hardly anybody goes off
Of steroids.
medication.
Correct.
And the third year,
So,
we do a liver biopsy, and if you
mm,
show it a normal liver biopsy, then you
uh,
can
correct.
attempt stopping. The
Trapping.
attempt, that word is very,
Yeah.
very important.
And
No one will get.
follow up very regularly thereafter
And
to
I don't
see
know
a
how can you
relapse.
ever get a normal liver biopsy. There will be in plasma cells, there will be inflammatory cells. So we are all giving small doses. That dose will be very small,
Yeah.
at least
Yeah.
2.5 milligram
Yes,
once
and
a day.
sometimes they hold off on 2.5.
So
2.5.
Yeah,
both of
and
you are
sometimes even 2.5 alternate day. I think it's just that
yeah,
it keeps the immune system in check.
correct.
And
That's
if
it.
you stop it, it just flares up.
So
So,
both
and
of you are in practice for decades. Which is the longest period you have now used as a therapy steroid without any issue, like 20, 10 years, 20 years, 30 years
So, I mean,
in the
Azathioprine,
same child?
transplant patients, so, azathioprine, but
No,
eventually
not
they
in
go on to a
transplant. I'm saying
single.
in autoimmune hepatitis.
I mean, have used it for an extended period of time, for,
Very extended
I
period.
mean,
All right.
maybe more than a decade.
Okay.
what I do
So
is after that third year, when they reach adolescence, we give them a small dose of steroid, Visalone itself, 2.5.
correct.
You
Okay.
might not require azathioprine, but we are giving azathioprine for years. Actually, we are more scared, I think, of azathioprine rather than it's a steroid sparing drug. I think
And
Absolutely.
also,
Absolutely.
we use it a fair bit in IBD.
IBD we are
Yeah,
using.
exactly.
Uh,
So, important question to both Dr. Malti and Ashay. When do you suspect drug as a cause of all the liver wounds? And Ashay, there was a paper of use of Giloy as an immunostimulant during COVID, and there was a paper from Bombay, adult side, of course, not pediatric. I don't know about pediatric, any cases have been reported, but acute hepatitis and liver failure needing transplant because of Giloy use. And they were taken to task saying that you are talking about a drug which is part of naturopathy or Ayurvedic therapy, etc. So first, Dr. Malti, when do you suspect drug as a cause of liver disorder?
So you have to suspect it whenever there's a temporal association to the ingestion of drug. It could be allopathy or CAM, which we call
Correct.
complementary alternative medicine. So any
Correct.
form of system of medicine can produce DILI.
But
That we have to.
generally, in your experience, the common drugs which have led to this type of issues?
Allopathy are drugs, the drugs which we, I think, face more often are anticonvulsants, but they, if you can stop,
Yeah.
recognize, they will produce. We have not had problem unless they've continued. And then
And on
we've
the CAM
had
side?
yes, anti-tuberculous, we've had issues, but then
Yeah.
we should know when to stop and when to do the next drug. And
And
now
the
I think
alternative medicine
awareness,
side?
Camp, yes, we are seeing, and
Yeah.
we always
Like which?
suspect. We do not know what they give, but they will say they gave
So generally,
Ayurveda,
these
they give.
are drugs which are purchased over the counter from a non-reliable source or a non-reliable pharmacy, and not under the prescription of a qualified Ayurvedic or such
Yes.
person. I think that's where we have seen many times the parents give drugs, some spurious drug to say as a immuno booster or as a health promoter, and they land up into this trouble.
Now we're getting problems with adolescents going to the gym and
Hmm.
getting testosterone for that produces a very
Oh
severe
God.
form of hepatitis where they even require plasmapheresis.
Oh
I've
my.
had a young boy who had to go for young adult going for plasmapheresis because he
My.
went and took that.
Oh my. And
So
Giloy,
those
Ashay,
Yes, sir. So basically, Giloy,
what is Giloy, by the way? I mean,
so the Giloy is an herbal supplement. Then the
okay.
name arrived from this Ayurveda, what he called
Uh-huh.
a Tinospora cordifolia.
Correct.
And many people in a COVID-19 used rampantly, and it
Mhm,
was a myth that this Giloy could be a divine elixir that can keep the people young forever. But
mhm, mhm,
there was a paper from Mumbai from a Dr. Abha Nagral madam.
mhm,
That paper highlighted that uh, 45 to 50 people ingested it Giloy, thinking as an immuno booster or an to boost the immunity.
mhm.
Within 45 days of ingestion, they had changes of the acute liver failure or this liver injury. So
Correct.
it is quite a dangerous drug. We should avoid from this.
Correct. All right. So last two questions. We are just last 10 minutes into this, and so I'll ask Anupam. Other rare viruses like CMV, EBV, Madam said, mainly in immunocompromised or even a healthy person, you would think of this viruses.
So mainly in immunocompromised, immunosuppressed, adeno is becoming quite interesting
Mhm.
now. In
So
the
adeno as a cause of acute hepatitis or a chronic hepatitis?
acute
Acute
hepatitis,
hepatitis. All right.
and of course, HSV in the very young
Mm-hmm. Mm-hmm.
babies can produce acute liver failure. CMV is something that we normally see in the post-transplant scenario, but anyone
Correct.
immunocompromised, immunosuppressed, you will see. EBV, Malti alluded to. So these are the ones that normally one would think of. Sometimes we get parvo, but then that's more hematology related, where you get aplastic anemia. But you can also get acute liver failure, and of course we did see some with the SARS-CoV-2 virus, we did see
Mm-hmm.
some liver dysfunction.
Okay. And the no discussion on hepatitis or liver disorder can end, and especially when Anupam is around, without talking about transplant. So quickly, in maybe 3-4 minutes, your
Yeah.
experience on liver transplant and hepatitis, or liver transplant and liver disorder in children.
So we, the first child we transplanted was in November 1998, 20-month-old baby with biliary atresia. He decided to choose medicine, became a doctor, and got married this year. He just completed 26 years post-transplant. So that's as far as liver transplantation in India goes.
Mm-hmm.
Over the years, we've done more than 4,700 transplants, including 571 in children. The
Mm-hmm.
vast majority of these are, of course, neonatal cholestasis, biliary atresia. And
Okay.
about 70% of the transplants that we do are less than age 2.
Mm-hmm.
As far as hepatitis goes, we've transplanted one child with hepatitis C who had
C. Okay.
who had hepatocellular carcinoma,
Okay.
and we've transplanted an adolescent with hepatitis B. Other
Mm-hmm.
than that, as far as viral hepatitis goes, we've had acute liver failure, and we've transplanted, I think, 9 or 10 children with acute liver failure due to hepatitis A.
Mm-hmm.
And
Combinations A plus E, A plus C,
these
never.
have just been
Okay.
pure Hep A. And
Uh-huh.
we've also transplanted 2 children with primary sclerosing cholangitis, which
Mm-hmm.
is part of the autoimmune spectrum. And we've transplanted I think 4 or 5 children with autoimmune hepatitis.
Okay. And what
So
about Wilson's?
Wilson's is a big chunk.
Mm-hmm.
Wilson's a big chunk. Wilson's can be split into two when they present with encephalopathy.
Mm-hmm.
Any child with Wilson's disease who presents with encephalopathy will die without a liver transplant. You cannot chelate them because it takes too much time. And
Correct.
there's just too much copper floating around. They basically get raised ICP and die. So any child with Wilson's who presents with encephalopathy needs a transplant. We've transplanted several of those. Unfortunately, we've also had children with chronic liver disease who've had Wilson's, which was missed because, ideally speaking, they should be well maintained on medication and not need a transplant. So
Correct.
Wilson's a significant chunk. Then, of course, the list is, includes a lot of other conditions like
Drugs.
choledochal cyst,
Acute PCM
which was
poisoning.
mixed. No paracetamol poisoning, some rat poisoning.
Any other rat poison? Okay.
And then, of course, we have a lot of progressive familial intrahepatic cholestasis now, or different varieties, because there's so many different types. What used to be 1, 2, and 3 has now expanded to at least 7, if not more. And then a couple of malignancies, hepatoblastoma, non-resectable, or in it's sort of come back.
And any
Hepatitis C.
combined liver kidney in children
Yeah, we've done that
for
for
metabolic disorders.
yeah, we've done that for hyperoxaluria.
Correct.
That's the condition where, if you don't do a liver transplant, the kidney failure will develop again because the oxalates will destroy the new kidney.
I think that's a good news that we have come a long way, and I think we have progressed very well, I would say, on the front of liver transplant. And now several centers, I know at least 3 or 4 in Bombay itself, which are doing excellent liver transplant even
Yeah.
pediatric patients. So
The
good to know
key
that.
thing for us is, of course, that, because this has been a long journey, 26 years, but for us, what has been very gratifying is that we've removed money from the equation. We've
Correct.
raised 26 crores in the last 6 years for pediatric liver transplants. So if we have a patient who has a liver failure and has a parent or a grandparent who's willing to donate, money is irrelevant. We've transplanted so many children below the poverty line with zero resources. So for
Perfect.
us, the most gratifying thing is that, yes, we have successful treatment, but more importantly, money is out of the equation.
Correct. So that comes to the last question that I had. Any wise advice first from Dr. Malti and then Dr. Ashay
Wise advice for?
for liver disorder in general in children?
Yes, I think
you
the
can-
preventable ones should be removed. Otherwise, we'll be continuing to talk on A and E. I think that itself is a big chunk which we
Correct.
should remove. And then Wilson disease early identification, if we are able to do the classic symptoms, if we can do ceruloplasmin to be included in all the things. Gamma GTP to be included in your liver biochemical tests of the liver, because you will pick up some metabolic disorders. I think that will be a thing which I would like to say.
In fact, that was the question, Dr.
Question
Jalil,
I
that
asked-
GGT
the question I
versus
asked.
PT as in an acute fulminant hepatic failure.
PT, no,
GGT
P time.
versus
Then
PT.
BTCT.
No, he's a GGT
Yeah, no,
versus PT.
GGT in acute liver failure, not really important.
Yes.
We are interested in prothrombin time. Gamma GTs
Prothrombin
were
time.
pointed towards,
Obstruction.
obstruction. And of course, we are not discussing cholestasis, but it is very
Correct.
relevant when
Or
you
the
are dealing with
metabolic
very young
progressive. Yeah.
Yeah.
for
Ash-
PFIC and bile acid synthetic
Right.
disorders.
That one group. Okay.
Right. Ashay, any last comment?
Yes, sir. Only 3 words: vaccine,
Uh-huh.
vaccine, vaccine.
So nice. I think thank you very much, all the 3 faculty, Dr. Anupam, Dr. Malti, Dr. Ashay, for taking out your valuable time on a very evening, odd hours, 9 to 10:30. But let me assure you, these are very interesting sessions which people enjoy because they are day-to-day practice. So, Dr. Ramesh, please conclude.
Yes,
Sir,
Nitin bhai.
one more question.
Jalil, yes, please.
Like a traumatic brain injury, do that traumatic liver injury can cause hepatitis, sir?
No, it basically with trauma, you'll die because of a bleed. So, I mean, if it's a major trauma, then you need to go in and fix the bleed. Sometimes you might have to do a partial hepatectomy. So fortunately, it's uncommon that we see such severe trauma. But otherwise, the liver is an amazing organ in terms of healing. So, if it's not bleeding too much, it will heal.
Correct. So the other thing which we commonly, I mean not commonly, but sometimes see is an acute hepatitis or huge hepatomegaly, high bilirubin is a sickling crisis which happens in
Yes.
liver and not in the spleen. So
Yes.
that's something you should always keep in mind. Yes, over to you, Dr. Ramesh.
So thank you so much, all the eminent panelists, Dr. Anupam Sibal sir, Malti ma'am, and Dr. Ashay for enlightening discussion. And retrospectively, I mean, it proved to be a very correct decision that Nitin bhai said that we'll keep only hepatitis. even not neonatal hepatitis.
Correct.
So please
We'll
be
discuss
ready.
that another time.
Please
Another
be
time,
ready
Because
for
sure,
there's
sure.
another
enough and
session.
more to discuss in
No,
neonatal
We are not going to leave
cholestasis.
you. Yeah, we surely. Correct.
And I am
Thank you.
very sure that our all friends, especially those who are in practice, they must have benefited tremendously by crisp and clear messages from all the panelists, because this is such a common disease and with vague ideas about treatment. So thank you so much again. Thank you so much, Dr. Trambak Datta, for providing us this platform. And
Thank you.
this will be uploaded on our YouTube channel, Gujarat Pediatrician WhatsApp group. So
Yes.
you can share it for the benefit of our colleagues. And finally, I mean, Dr. Nitin Bhai always makes a subject so easy
Thank you so much.
by connecting the cases, be it rheumatology, be it, in fact, you will be happy to know that last our webinar growth chart, and he made it such an easy, this thing, there are so many praises I got from eminent academicians across the country. So we were laughingly telling you whether you will be practicing as a vaccinologist or now as a
Growth and pediatrics.
So I will tell you one secret is it's very easy to ask questions.
But very well conducted. Your choice of
Very
questions was
well,
very
very,
suitable.
very
So we
nice.
had a wonderful time, great learning experience. Thank you.
so
All
much.
right,
Thank
everyone.
you
Have a
so
good
much.
night.
Thank you.
Bye-bye.
Good
Thank
night.
Thank you
you.
so much,
Thank
everybody.
you.
Thank you, Ramesh
Bye-bye.
sir, for chance.
So Tech, we can stop recording. Thank you.
Yeah, thanks.
All right. Okay.
Thanks
Bye-bye.
a lot. Bye-bye. Good
Bye.
night.
Good night. Bye, sir.
And
Thanks.
Nitin Bhai's daughter is getting married and still